We talked earlier about the other vital signs, temperature, heart rate, and blood pressure. And so now that we're starting to get into respiratory disorders, we're going to talk about the interpretation of the vital signs of respiratory rate and oxygen saturation. So the learning objectives are the same for the other vital signs. And the respiratory rate is the number of breaths taken per minute. Easy squeezy, right? But it's also important to note the depth and pattern of breathing. So is it regular? Is it irregular? Is it deep? Is it shallow? Where's the person breathing? And when we do pulmonary rehab, we will talk about segmental breathing patterns and kind of assess those. So on the telemetry monitor, here's our respiratory rate, and you can see that it goes up and down. It's not just doesn't just stay steady like your oxygen saturation is going to stay steady, but the respiratory rate is going to go up and down. Normal resting rate is 12 to 20 breaths per minute. Tachypnea, which is fast breathing, is greater than 24 breaths per minute, and bradypnea is less than or equal to 10 breaths per minute. We want to also monitor breathing depth, rhythm, and sound in addition to the rate. So some of the definitions that we're going to talk about in the next part of the lecture are the different breath sounds and what's normal and what's abnormal. And then in the lab for pulmonary rehab, we're going to listen. We're going to auscultate with a stethoscope, listen to those breath sounds. So in general, expiration should be twice as long as inspiration. So inhale and then exhale twice as long. Of the four vital signs, so temperature, heart rate, blood pressure, and respiratory rate, um, respiratory rate is the most frequently missing in the medical record, even when the patient's primary diagnosis is respiratory specific. So that is interesting. There were several studies that noticed that. And the interesting thing is that respiratory rate is one of the clearest indicators of a deterioration. So we should get in the habit of measuring respiratory rate. And just thinking about it, I think it is sometimes a little bit harder to measure respiratory rate because you have to do it in such a way that the patient doesn't realize you're measuring it. Because respiratory, unlike our other vital signs, we can change our respiratory rate voluntarily. We can't change our heart rate, we can't change our blood pressure, but we can change our respiratory rate. So if somebody says, okay, I'm going to measure your respiratory rate, you're probably going to change how you're doing it. So you have to be a little bit sneaky with respiratory rate. And that's what I suspect as being a factor in the fact that it's most frequently missing in the medical record. And I've got to say, when I take a set of vitals, I don't usually do respiratory rate. I might do it now, but here we go. So during exercise, the respiratory rate and depth should increase. That makes sense. Higher oxygen demand, we want more an increased respiratory rate. Respiratory rate is a stronger correlation of rate of perceived exertion than heart rate. So usually when we're perceiving that we're at a certain level of exertion, we're perceiving that our breathing speeds up and maybe we can't talk in full sentences or we have to pause between words. So respiratory rate is a strong correlate of rate of perceived exertion. Once you get to a steady state, cardio, your respiratory rate remains relatively constant if the intensity of the exercise is constant. So if you're these people walking or running on the treadmill at a constant rate, your respiratory rate, once it reaches your aerobic steady state, it's probably going to stay about the same. Breathing rates return to normal within 10 to 20 minutes after a primarily aerobic fitness session. Respiratory rate and depth remain elevated during the recovery period, so we can expel the CO2 that was produced from cellular metabolism. So we get that elevated respiratory rate to get rid of the excess CO2 and balance out our acid-base balance. So abnormal breathing patterns, and we'll talk about these in several places during this respiratory chapter, and when we talk about pulmonary rehab in the special topics class, we will revisit this. But dyspnea is the subjective sensation of difficulty breathing or shortness of breath. Um, Paroxysmal nocturnal dyspnea. So paroxysmal means it comes on suddenly. Nocturnal means it's at night. And dyspnea is subjective sensation of difficulty breathing. So it's when you have difficulty breathing at night. And some people are fine during the day, but at night they have dyspnea. Orthopnea is dyspnea when you're supine or lying flat. It is generally relieved by not lying flat. So elevating the head of the bed or adding pillows. Sometimes orthopnea is a symptom that a patient will report to you and they'll say, I need to sleep on 3 pillows in order to feel like I'm breathing. Or I need to sleep on 4 pillows or 2 pillows or whatever. So number of pillows is a measurement of orthopnea sometimes. Hyperpnea, which I think is a great word, but hyperpnea, say it, it's fun. Increased depth of respiration with or without a higher respiratory rate. So you're just breathing more deeply. You may not be breathing faster. Kane-Stokes breathing is usually associated with the end of life. It's a decrease in the depth of respiration followed by, an increase in the depth of respiration followed by a decrease, and then a period of apnea. So a lot of times, if say that you have a loved one or friend in hospice, the hospice workers will tell you to look for that. You'll see times when they don't seem to be breathing, and then they take a deep breath, and then they don't seem to be breathing. So Kane-Stokes breathing usually happens at the end of life. Kussmaul respirations, on the other hand, do not. But it's an increased rate and depth. It can be a regular rate, but more depth. And sometimes it's described as air hunger, like you're gasping for air, tachypnea and hyperpnea at the same time. Buyout respirations are rapid, deep inspirations followed by periods of apnea. And agonal breathing is slow, irregular respirations that can often progress to apnea. And then apnea is just the absence of breathing. So apnea is a medical emergency. If you're not breathing, something's got to change, right? So apnea is the worst abnormal breathing pattern, I guess, if you want to think of it that way. To accurately measure the respiratory rate, the patient should be unaware that their respiration is being examined. And so, what a lot of medical professionals do is you're taking their pulse and you rest their arm on their chest. So, you count their pulse for however long you're going to do it, 60 seconds usually, and then you count their respiration for 60 seconds. They think you're still taking their pulse, but really you're taking their respirations for part of the time. You want to ensure that the patient has adequate resting time so they're not out of breath from rushing into the clinic or getting out of bed or something like that. You want to measure for a full 60 seconds. The reason you want to measure for a full 60 seconds is because obviously when we're measuring heart rate, the normal is 60 to 100. Even if you measure for 30 seconds, you're getting a good number of heart rates. Well, the normal respiratory rate is a lot lower, and so you're not getting the same number of respirations in a minute. And so if you measure for a full minute, you'll account for irregular breaths and you avoid underscoring respiratory rate. So you do want to measure respiratory rate for a full 60 seconds. Again, respiratory rates are not frequently recorded in the medical record, and maybe we need to change that, particularly with people with respiratory diagnoses. So for rehab, we need to educate our patients in breathing strategies, either to reduce the respiratory rate or reduce the work of breathing. So we will, in our special topics class, we will talk about different types of breathing and practice educating our patients in different types of breathing. You probably also, in some of your other classes, you'll do that, but it's really important. I spend a lot of time in outpatient and in inpatient educating people on breathing strategies. It's very important for exercise. It's very important for just efficiency and pacing. Patients often need instruction in pacing, and I know I've talked about this in class sometimes, certain patients where they really needed some education in pacing. It's really important. And energy conservation. When you have someone who has a pulmonary disorder, using intermittent exercise by alternating periods of activity with periods of rest is a really good way to approach exercise for someone whose respiratory system is compromised. And warm up and cool down periods are super important for managing breathing and respiratory rate. Respiratory rate can be a strong predictor of subsequent clinical deterioration. So that is something we want to think about. If somebody's respiratory rate is out of range, either too low or too high, they could be heading into a bad place. That might be something we should report to their doctor. So, recommendations for exercise. We do not want to initiate or continue exercise if the respiratory rate is less than 5 or greater than 40 breaths per minute. So if they're greater than 40 breaths per minute, you might just need to rest. I mean, that might be the thing. And then it goes back down, and then you can resume exercise. If it stays at 40 breaths per minute, well, then you don't want to continue. If it's that far out of range, you don't even want to start. And obviously, if it's too low, they're just not going to be getting enough oxygen. Adult patients with respiratory rate of greater than 24 breaths per minute should be monitored closely and reviewed regularly, even if their other vital signs are normal. So that is something we can really look at a lot when we're exercising. Respiratory rate of greater than 24 breaths per minute combined with other evidence of physiological instability like low blood pressure, you should get medical clearance before you continue PT with them, before you continue exercise. And patients with a respiratory rate of greater than 27 breaths per minute should receive medical clearance as well. So there are some times when you're like, maybe their other vitals aren't out of range, but their respiratory rate is way too high. And so you want to make sure that something's not going on. They're not having a clinical deterioration. Because remember, respiratory rate is a strong predictor of subsequent clinical deterioration. So that could be the first clue we have that somebody's getting worse. For oxygen saturation, it's the 5th vital sign, we're going to call it that. It's not one of your standard ones, but it's one that we use a lot in rehab in the clinic. And O2 sat is the percentage of hemoglobin that's saturated with oxygen, and it's expressed as a percentage. So it's 90%, 100%. In simple terms, it's the amount of oxygen circulating in the blood. The standard, the gold standard, we said for heart rate, the gold standard was an EKG, but that's not something that all of us have access to. The gold standard for oxygen saturation is arterial blood gases. Again, we don't all have access to that, but we all do have access to pulse oximetry, and it's non-invasive, which is lovely. So pulse oximetry can either use a finger peripherally or a central ear or forehead sensor sites. Sometimes if you have people with poor circulation or very elderly people, you often can't get a good reading on their finger. So if you have an ear or forehead sensor, you get a lot better readings because it's a more central site. Normal SpO2 resting is 95 to 100%. 90 to 94% is considered mild hypoxemia. That's considered low or abnormal, and it indicates a need for oxygen. It doesn't necessarily indicate a need for supplemental oxygen, but it indicates a need that maybe you need to coach the patient on breathing a little bit. So moderate hypoxemia is 85 to 89%. Severe hypoxemia is 80 to 84%, and extreme hypoxemia is less than 80%. A lot of times when you're working in acute care, people are on continuous monitoring, and if the SpO2 goes below 85, it beeps, and it keeps beeping. So either you have to get their oxygen level up somehow, or get medical clearance, something's going on. There are people who have chronic obstructive pulmonary diseases like emphysema or chronic bronchitis who live in a state of hypoxemia. They live in that 85 to 89 range. That's normal for them. It's not normal, but it's what they have. And so you might get people that have pretty low oxygen saturations if they have respiratory diagnoses. The signs and symptoms of hypoxemia are dyspnea, labored breathing, tachypnea, tachycardia, headache, and confusion. Obviously, the more extreme or severe the hypoxemia, the more you're get into the more severe signs and symptoms. So SpO2 shouldn't change significantly during exercise. If somebody comes in and they're kind of slumped over and not breathing very well, and then they come in and they start to exercise, their SpO2 might go up just because they're breathing better and they have better posture. But in general, it doesn't change significantly. It's not going to go from 80 to 100. The pulse oximetry might not always be the most reliable method to predict arterial oxygen saturation during exercise, but it is one that is easily accessible and non-invasive. The FDA considers pulse oximetry to be an estimate of oxygen saturation. So if you read on your pulse oximeter 90%, it might represent an actual arterial saturation of 86 to 94%. So there's a little bit of slush in the measurement, if you want to think of it that way. So measuring someone's oxygen saturation is not a replacement for measuring their respiratory rate. You're going to get other information from the respiratory rate, so you should do both of them. An abnormal response in oxygen saturation, if you have less than I'm sorry, greater than or equal to 5% decrease is considered abnormal. So if you start exercising and you desaturate more than 5%, that's an abnormal response. You should terminate exercise if your oxygen saturation is less than or equal to 80%, especially when accompanied by signs and symptoms of hypoxemia. So tachypnea, tachycardia, dyspnea, all those things we listed up there. So yeah, stop exercising if it gets that low. When we do our pulmonary rehab lab, we'll talk about how we're going to moderate that when we're doing certain testing, like a 6-minute walk test or that sort of thing. So pretty important thing to be monitoring. In order to be accurate, we have to have accurate measurement techniques. So it's going to be less accurate for someone with poor circulation, somebody with skin pigmentation, thicker skin, if your hands are really cold, you're not going to get a good reading with a pulse oximeter. If people use tobacco, it diminishes their circulation and you might not get a good reading. Motion artifact, meaning they're moving around and they're not getting good contact. And fingernail polish. So fingernail polish diminishes the accuracy of your reading. The pulse oximeter accuracy is best at saturations of 90 to 100. And it's like okay at 80 to 90, and below 90, it's not that good in terms of accuracy. So then if somebody's really at that rate, they probably want to get arterial blood gases to get an actual oxygen saturation. Earlobe placement of oximeters can provide more accuracy than fingertip placement, particularly with people with poor circulation, elderly people, people who just have chronically poor circulation and cold hands. Sometimes if you put an elastic band around the sensor, you get a better reading. So that's something to think about. So at rest, normal respiratory rate is 12 to 20 breaths per minute. Normal oxygen saturation 95 to 100%. With exercise, respiratory rate should increase and oxygen saturation should remain relatively unchanged. Respiratory rate is the most neglected vital sign, despite being a strong predictor of clinical deterioration. So that's interesting. Maybe we can change that. We can go out in the clinic and change that. Exercise needs to be terminated if your oxygen saturation is less than or equal to 80%, especially when accompanied by signs and symptoms of hypoxemia. And it's important to be aware of factors that influence accuracy in measurement and interpretation of respiratory rate and oxygen saturation. So those are kind of our go-to things for people with respiratory disorders, but cardiac disorders might affect those as well. Other considerations for vital signs, older adults are at a higher risk for adverse events when changes occur outside the vital sign reference range because they have a decreased ability to compensate. So older adults also don't have the same temperature profile as younger adults. So something that might make a younger adult's temperature go up is not going to have that effect on an older person, and they're going to have a different kind of effect. So it's really important to be aware if you're working with elderly people that they have a decreased ability to compensate for changes in vital signs. It's also important to be aware of vital sign parameters for specific health conditions to optimize safety during rehab sessions. So when patients have multiple comorbidities, so they have congestive heart failure and COPD and this, and you see that a lot, unfortunately. It is recommended that you start when you're starting an exercise program, you want to do it based on the most restrictive pathology. So what one is giving them the most restrictions, you want to start there and work your way up. So vital signs are important for your clinical decision making, but you also have to look at what else is going on with the patient and depend on your clinical judgment. So it is just one piece of data that we're working with. So we are going to be working with people with lots of different diagnoses. And even if you're working in an orthopedic clinic, you can have somebody come in with a post-surgical knee, and they also have COPD, and they also have, other things. So it's really important to know their medical status. And if you have any questions about safety or medical stability or individual vital sign parameters that you need to be aware of with this person, make sure you connect with the medical team to make sure that you're aware of those and you're giving your patient the best care you can.